Hello, my name is Nancy Weintraub. I am a clinical professor of medicine at UCLA. I'm also the director of the combined UCLA Greater Los Angeles VA Geriatric Medicine Fellowship. I'm an internist with extra training in geriatrics, and thank you all for listening and watching today. I am going to be talking about eating problems in patients who have dementia, which is unfortunately a very common problem, but something that is not often discussed. So, as most people who have any experience with patients with dementia know, as the disease progresses, people lose more and more abilities to care for themselves. Usually, the final ability that people lose is the ability to independently feed oneself. And for patients who live long enough, feeding problems will affect over 85% of patients with advanced dementia. Swallowing is an incredibly complicated process. It involves about 50 pairs of muscles. Some of the muscles are voluntarily controlled. Think about chewing. You know when you're doing that. Some are not voluntarily controlled. They're involuntarily controlled by reflexes that come from the brain. And to coordinate that is extremely complicated. And so just as people lose the ability to coordinate walking or dressing or speaking, they also, over time, will lose the ability to coordinate swallowing. Commonly, we'll see people who will take food into their mouths and just chew. And they'll chew it, and then they'll kind of move it around. And an hour later, if you look, it's still there because they kind of forget what to do with it. It's a very common problem. This is what I just said. People who have particular expertise in this area are speech therapists. Speech therapists evaluate swallowing problems and can sometimes help by recommending particular types of consistencies of food and liquids for individual people. Unfortunately, when someone is demented, you can't really teach them tricks to use to swallow better, but you can adjust the consistency of their foods. There are two types usually of swallowing studies. One is done at the bedside where a therapist will just come and watch somebody swallow. They'll feel the person's neck as they're swallowing. They'll try different consistencies of food and liquids and see what seems to be working better. The other type that is sort of the gold standard of swallowing studies is a fluoroscopic study with barium. It's also called sometimes a barium swallow. And what happens in that is the person who's being tested will be given various consistencies of food and liquids to eat and drink. And the foods and liquids have barium mixed in with them. And so they will do this in a radiology department. And the speech therapist will actually make tape of the person swallowing and can analyze it, see where the food is going and what is happening. The final type, which I don't have listed on this slide, is also a bedside study. It's usually done in people who are hospitalized and very sick because it's not as good as the fluoroscopic study, but it can be done in people who are too ill to go down to radiology. And what the speech therapist does there is they thread a fiber optic coil into through the nose usually into somebody's pharynx, and they can watch them swallow that way. The problem is that when you actually swallow, the whole pharynx closes down, and so that for that really important moment, you can't see anything. But the more typical type that caregivers will encounter is the fluoroscopic study. There are a couple of things that can be used for people with specific types of problems. This is in terms of either feeding themselves, when you're trying to preserve people's independence as long as possible, or for people who need to be fed. So for those patients who might have a tremor, and if you've ever tried or watched somebody with a tremor try to eat, what happens is you'll take the spoon and scoop up some peas, and your tremor will cause the peas to fly all over the place, and you can never actually manage to get them into your mouth. So what weighted utensils do, they're just typical knives, forks, and spoons, but the handle is heavy. And so what it does is it takes a fine tremor and turns it into a more slow tremor, and so it's easier to control. So people, for example, who have Parkinson's disease or other types of tremors find those very useful. People who have only use of one hand, for example, will often find that bowls with lips on them are very useful. And there are bowls with lips that are made that also have a rubber circle on the bottom. So you have a rubber circle and the bowl will be raised on one side. It's kind of a plate with a lip. And you can scoop things against your spoon or your fork if you can't use your other hand. Finally, for people who don't have use of their fingers at all, typically this will happen after a neck injury or some people with strokes, but they still have use of the muscles of their arms. You can get a cuff, which is basically a bracelet, and it fits onto the arm, and the utensil comes off the cuff, and you can eat this way, so you don't have to use your fingers. For people who need to be fed, they have lost the ability to feed themselves. The best thing that a caregiver can do is get one of those long-handled baby spoons that you probably remember from feeding toddlers or little tiny children. The advantage of that is that the spoon itself is very small, and patients who have difficulty with swallowing, with dealing with food in their mouths, do way better with smaller bites. And so it slows the whole process down, and they are more able to deal with the food that is presented to them. I mentioned before that speech therapists might recommend different consistencies of foods and liquids. The typical ones that are suggested are going from more normal to less normal. It is soft. Soft is kind of what you think it is. It's just not really hard consistency food. Often, a piece of boiled chicken will count as a soft food. Well-cooked vegetables count as soft foods. The next step is diced. Diced is more like hamburger. There are no big chunks of anything. Everything is presented in smaller bits. And then pureed is exactly what you think. It's like if you ever made baby food, everything goes into the blender. And that is for people who have trouble swallowing and dealing with, who have trouble chewing and dealing with moving the chewed food through their mouths. Most commonly, the real problem people have is with liquids. The reason for that is liquids, when you take liquid into your mouth, it does not stay together in a clump. It's just this sloshy thing that's rolling around in there. And so what will happen is when you initiate a swallow, if your swallow is not completely, perfectly timed, some of it may move back, some of it may stay forward, some of it will go down too quickly, it will go down the wrong way, it can go down into your trachea, towards your lungs, instead of into your esophagus, towards your stomach. And it is easier to manage liquids that are thick. There are two types of thicknesses that speech therapists may recommend. One is nectar thick, which is just like a thick juice, like a peach nectar. And the other is honey thick, which is really thick. It's honey. It does not feel like liquid when you drink it. In fact, it's really difficult to drink it. You have to kind of take it with a spoon. It's more like a pudding. The problem with these is that they don't really quench thirst. People don't like to drink them, and you can develop dehydration because people just don't like to drink them very much. One way to try to get around this problem is that even people who tend to have a lot of swallowing difficulties, stuff is going down the wrong way. They may have aspiration. That means it gets all the way down into the lungs. Maybe they've had aspiration pneumonia. They have a lot of difficulty, particularly with liquids. If the mouth is clean, so no food in the mouth, no really rotten teeth, you can take water fairly safely, because even if you aspirate water, it doesn't matter. You're not going to drown from a glass of water, and you are probably not going to get pneumonia from a glass of water if the mouth is clean. So oral hygiene is incredibly important for people as they progress through their dementia. It's something that they usually can't take care of themselves anymore. Someone else has to do it. It can be really challenging to do, but it can make an enormous difference to how they manage with these swallowing difficulties. Okay, what about feeding tubes? I'm going to talk about feeding tubes, and then I'm going to explain to you why I think they're a bad idea. But first, I'm going to tell you what they are. There are typically two common types of feeding tubes. There's a nasogastric tube, also called an NG tube, and the more common one is referred to as the PEG tube, which stands for percutaneous endoscopic gastrostomy tube, and I'm going to explain that in a moment or two. I'm going to talk first about the NG tube. The advantage of the NG tube is that it can be inserted at the bedside. Doctors can put it in, nurses can put it in. It is almost never used for a long period of time. It's extremely uncomfortable. It can only be used for a few days because it creates pressure on the nose. It goes through the nose. And it actually increases a person's risk of aspiration, because this is a cartoon of a nasogastric tube. As you see, it goes in the nose and down the esophagus and into the stomach. So in order to swallow safely and not aspirate, you have to be able to close off the two systems from each other. And the systems run right next to each other. You have your esophagus, and then you have your trachea. And the NG tube is in the way. it stops your ability to close off the tubes from each other. So people with NG tubes routinely have aspirate. So this is not used to prevent aspiration. This is used usually short term for somebody who's very sick and in the hospital and can't eat for one reason or another. For people who can't eat for long periods of time, the most common type of feeding tube that is used is the PEG tube. There are very good reasons for people to have PEG tubes. I'm going to give you just a couple of examples of those. People who have cancer in their mouths and are being treated and can't swallow because they're being treated for this. They may have a lot of inflammation or something. They cannot swallow at all. They need to get a PEG tube so that they can go through their treatment. People who have had strokes and lose the ability to swallow right then from the stroke and are otherwise recovering really need to be fed by PEG tube because they are trying to recover from their stroke. They have a disease from which they may recuperate. And in fact, many people who lose the ability to swallow from strokes regain the ability over time, even over years. Up to 2 years later, people can regain the ability to swallow after a stroke. The way a PEG tube works is it goes from the stomach inside through an incision in the abdominal wall to the outside of the belly. And I'm going to show you a picture of it in a minute. They can be left in place indefinitely. PEG tubes don't have to be removed. They don't have to be changed. They just live there. Problems are that they can leak, they can clog, they can cause infection in the skin and the tissues around the tube. They can be pulled out by a confused person and then have to be reinserted. The other thing is that when people with dementia are given PEG tubes, the most common response is, "What is this?" And then they pull on it and they try to pull it out, which strikes me as a reasonable response. And as a consequence of that, demented people who have PEG tubes are often either sedated so that they don't mess with their tubes, or they're restrained so that they don't mess with their tubes, which to me is not a good outcome. This is a picture of a belly of a man who has a PEG tube. And this is the tube. That's the end that gets another tube attached to it. And liquid nutrition, liquid food, goes in here and goes straight into the stomach. Putting this in is a surgical procedure. It involves putting a tube down through the mouth into the stomach and poking through, basically making an incision, poking through, and the tube stays there. It's got a bumper on the inside of the stomach. It's got a bumper on the skin. And the two of them, opposed to each other, keep the tube from moving around too much. But as I was saying, you can have leakage around this. You can have infection around here. Sometimes the tubes clog and have to be changed. They are not easy. This looks pretty simple, but they are not easy to live with long term. So let's say you are caring for a loved one who has dementia that has progressed to the point that they are not eating well and they are not able to keep up with their nutritional needs. They're losing weight. Maybe they have had pneumonias from aspirating contents in their mouth, food in their mouths. And you kind of at your wit's end, right? Because like, well, what am I going to do now? My loved one is wasting away and starving to death. Should I think about putting in a feeding tube, a PEG tube? So the questions that one would want to ask in that setting are, do PEG tubes actually help with nutrition? Do they prevent aspiration pneumonia? If someone has a wound somewhere, will better nutrition from a PEG tube help the wound heal better? Will a person live longer if they have the PEG tube inserted? Remember, we're talking about people who have had dementia for a long time, who are kind of at the end stages of their disease. Will a PEG tube make somebody stronger and maybe help them regain some of their function? So counterintuitively, and surprisingly, the answer to all of these questions is no. These questions have all been studied separately. There's a lot of literature that has accumulated now. And PEG tubes don't help with any of these things. They don't cause people who are demented to regain weight. Why not? That doesn't make sense. If somebody was eating really poorly and losing weight, and suddenly you're giving them nutrition, why do they not regain weight? Nobody really knows the answer to that. There are a couple of possible explanations. One is dementia is a whole body disease. It's not just a disease of your brain. People with dementia have a lot of inflammation, just like people with cancer do. And they lose weight. At the end stages, it causes them to lose weight. Other reasons may be, excuse me, that it is hard to give someone enough nutrition through a PEG tube to keep their weight stable. Liquid feedings through PEG tubes tend to give people diarrhea, so you have to cut back sometimes. They can accumulate in the stomach, and you can't give somebody more when their stomach is still full. So surprisingly, at least it was surprising to me, they do not help with improving nutrition. Since they don't help with that, they also are not, it is not likely to help with making somebody stronger, because if your nutrition's not getting better, you have no reason to get stronger. And you're not going to regain function because the loss of function is a consequence of the disease, and the disease is dementia. And people who have dementia, if they don't die of something else, will eventually die of their dementing illness. It is a terminal disease. So when we look at survival in people who have dementia and can no longer feed themselves, and we compare the survivals of those people who have gotten PEG tubes and those people who have continued to be fed by hand, the survival data, that when you graph it, the graphs are totally superimposable. People with PEG tubes do not live longer. Similarly, their wounds don't heal. And finally, PEG tubes do not prevent aspiration pneumonia. That's also a little surprising, because you are bypassing the mouth. And the only place where your two systems that we're talking about here, the system through which you breathe and the system through which you eat, interact, are up in the pharynx and the mouth, right? That's the highest point. There's no place down here where they're communicating. However, what happens with people who are fed by tube is, like everybody else, they have reflux, which means stomach contents will come back up into the mouth sometimes and can go into the lungs, just the same way it could when people were eating. And so aspiration pneumonia does not actually stop happening in people with PEG tubes. It is often recommended for that reason. A person who has dementia will get pneumonia. It is felt to be due to aspiration. Person goes to the hospital, and the team at the hospital will say, oh my goodness, this person aspirated. We can't have that happen again. Let's put in a PEG tube. Unfortunately, the sort of larger general population of doctors don't know this literature. This is something that I deal with all the time when my patients get hospitalized. It will not help with this problem. And before I get to my couple of final tips, well, the other reason I don't like PEG tubes, in addition to the fact that they don't do anything useful, is, and by the way, our professional society, the American Geriatric Society, recommends against placing feeding tubes in people with advanced dementia because it is, number one, not useful, and number two, creates cost and kind of misery because people now have this thing that has to be dealt with. If it gets infected, you have to get antibiotics. If it comes out, you have to go back to the hospital and have it put back in. It's just a very messy process that really doesn't have any upside in this particular population of patients. Finally, the other reason I don't like it is often people who are demented don't have a lot of opportunity to interact with other people. Their ability to interact with the world is tremendously restricted. They can't talk anymore. They can't understand what's going on around them. If you have a PEG tube, all that has to happen to be fed is somebody runs in, hooks up the feeding, and runs out again. If you have to be fed by hand with the long-handled baby spoon that I was talking about before, what we are talking about is maybe a 30 to 60-minute encounter with another human being who is sitting and looking straight at your face. And that may be the only face-to-face contact a demented person will have over the course of their day. It is the culture that I grew up in. Feeding people is, a sign of love. And it is a way of communicating even with people who cannot communicate anymore. Couple of final tips on my last slide. I think this is my last slide. Straws, for people who have swallowing problems, straws should be avoided at all times. Straws are bad. When I go and see patients in the hospital, they've always got cups of water with straws in them, and I just go around and collect the straws. The problem with straws is when you put a straw in your mouth and you sip liquid, it goes straight to the back of your throat. And if you have any disorganization in your swallow process, you have no time to deal with that. It's just there, and it's going the wrong way. So straws are a really bad idea. Coughing, on the other hand, is a good thing. If you notice that when you feed somebody they cough, that means that the reflex that notices that food is going in the wrong place has actually been activated. And so, oh my goodness, my food is going down the wrong tube. I'm going to cough and try and clear it out. So coughing does indicate that there's a problem, but it's also a partial solution to the problem. And that's my prepared talk, and I think I might have time just for a couple of questions that might have come in. So I'm waiting to see the questions. Thank you. Okay. So one of the questions is about motivating people who are demented to eat. So one thing that I always say is for my patients who have kind of progressed to the point at which they're not eating much, they really are not interested, all recommendations concerning diet are out the window. I don't care if somebody lives on ice cream. Whatever they like, that's what they should eat. Part of normal aging is losing some of your smell and some of your taste abilities. So if you're demented and things don't really smell delicious and don't have much taste, why would you bother with them? So it's, my feeling is I'm not going to worry about people's blood pressure. I'm not going to worry about people's heart disease. I worry about the diabetes a little, but we can usually deal with that. Give them whatever they want. And frequently, people get overwhelmed by large plates of food. So what you want to do is offer people what you think they like and offer it frequently during the day. And another question is, are mind-body approaches or exercise useful? So, unfortunately, when someone has reached this point, the point that I'm talking about in their dementing illness, they usually can't exercise anymore. But certainly, exercise is the best intervention that anyone has found so far in, number one, trying to prevent dementia, trying to preserve memory, and stimulate appetite. It's also really good for sleeping. So demented people should exercise as much as they can. It will help them sleep and it will help them eat. I think, unfortunately, that we have run out of time. So I want to thank you all for your attention and have a good rest of your day.